use the terminology ketone metabolic therapy, and that's much better because there are many types of ketogenic diets, and for all intents and purposes, you wouldn't want to use the original clinical ketogenic diet anyway. We use
Right,
highly
right,
modified versions, higher in
right.
protein. It's got fiber in it, it's got a certain fatty acid profile, and it's essentially like an engineered, personalized, prescriptive metabolic therapy. It's far different than the original diets used for epilepsy.
All right, Dom, good to see you, my friend.
Great to see you again, Scott.
So actually, Dom, you were one of our first guests at the formerly known as the Smarter Not Harder podcast. And now, as we are now the Health Optimization Medicine podcast. And I really wanted to bring you back because you are the premier researcher, the guy that knows more about the world of the ketogenic diet, ketogenic metabolic therapies more than anybody. And I think what was super interesting is that it became like this fad thing, as you and I know, like 3 or 4 years ago, everything was like keto, everything, keto ice cream, keto pizza. And like, we know how things go with fads. They go up and they come back down, but it doesn't mean that the research is any less relevant because it's not as popular, right? And actually we've seen something similar with methylene blue recently at prescriptions, where huge spike in 2025, and now it's come back down to earth on some level, but it still doesn't mean that there isn't significant amounts of potential with this particular compound. So I'm really happy you've been out there on the airwaves, doing your thing and talking. And today what I wanted to do is personally, I've been confused with all the types of ketogenic products that have been on the market. There's the beta hydroxybutyrates, there's acetoacetates, there's the 1,3-butane-diol. So I think maybe in the beginning, before we get into the details and talking about some of the cool things that you're doing in research, maybe kind of define or just give us the lay of the land, Dom. Like, what's happening in the world of a ketogenic supplementation, and then maybe, if you want, what we can do as a starting point, we can define what ketone metabolic therapies are, and then from there kind of talk about the lay of the land as it is now.
Yeah, I'm glad you brought up sort of, I guess you're referring to like the Google Analytics on
Yes.
keto kind of
Yeah.
exploded maybe about 10 years ago or something. So I pay far less attention to the Google Analytics, but my attention is typically paid to PubMed. So if you
Mm.
look at PubMed, which is peer-reviewed literature on ketogenic diets and ketone supplementation, and if you look on clinicaltrials.gov, which is registered clinical trials doing research on ketogenic diets or ketone supplements, that growth has been exponential and has actually gone up significantly in the last 5 years, like exponentially.
Mm-hmm.
But I think Google Trends have their mind of their own depending upon what influencer is talking about them. So from my
Yeah.
perspective as a research scientist, yeah, I'm more excited now than ever because the trajectory of ketone research is growing exponentially.
Mm-hmm.
So we use the term ketone metabolic therapy or ketogenic metabolic therapy to describe a ketogenic diet and different versions of that, but also exogenous ketone supplementation, which there are many forms of that in the form of exogenous electrolyte salts, ketone esters, diols. 1,3-butane-diol is a precursor. MCT is considered a ketogenic supplement. And, we've kind of, on paper, we have like 30 different compounds, right, that are very ketogenic that kind of will be bioactive in some way when they're orally consumed. So that's a pretty big category that's emerging in sort of the innovative aspect of a ketone. And these things are not mutually exclusive. So you have ketogenic diets, and then you have ketone supplementation and things like intermittent fasting, which can produce ketosis. So these things can be used situationally, in combination or as a standalone kind of therapy, right?
Right. I mean, I think certainly there's a very much of difference between being in the research world and seeing what's going on versus the popular, the popular world of fads. And that's, I can imagine why you have to avoid the word diet, is because obviously fad and diet are very much combined in popular culture, right? And there's a significant difference as well when we're talking about, the ketogenic diet versus ketone supplementation, right? And I think that, what's happened a lot over the last several years is that, you don't have to follow the diet. All you need to be is on the supplements, right? But I think that's a little bit of a not exactly correct idea. So how do you typically piece that out for people when you say, like you should be on the ketogenic diet, or maybe you should be on supplementation to help ketones? It very much depends on the person, I would imagine. How do you think about that?
Yeah, it's a good topic. A good topic of discussion, because I think people that market ketone supplements talk about it as a replacement to a diet. And that's not. So there are definitely overlapping physiological and metabolic similarities
Hmm.
with ketones, but a clinical ketogenic diet would involve a level of carbohydrate restriction that significantly shifts your metabolism to fatty acid oxidation and ketone
Right.
metabolism.
Right.
So that's a big, and if you are on a high carb diet and you take exogenous ketones, you are shifting metabolism more towards ketone metabolism, but not necessarily fatty acid metabolism. So, although ideally, I mean, my approach, what I do is like a low carb, if you want to call it, I don't like the term Mediterranean-ish diet,
Hmm.
but sort of a higher protein ketogenic diet that has a mix of, vegetables and fruits and things like that.
Hmm.
But it's restricted enough in digestible carbohydrates that I maintain like a low level of nutritional ketosis, bouncing around 0.5 to 1 millimolar later in the day. And then, supplement periodically, situationally when it's beneficial.
Yeah.
And also, on some days I won't have the first meal until like noon or 2. And if I have a heavy workload in the morning, I
Yeah.
just tend to be a little bit more lucid and quick with my thinking and everything. So that's an important like sort of consideration. The problem with a ketogenic diet will always be for many people the high fat.
Yeah.
So
For
it
sure.
is hard especially for people who have a high metabolism to consume that amount of fat, and consuming that amount of fat every day, all day, every day, can produce some abnormalities in blood work that
Yeah.
are
Yeah.
maybe not perceived as like optimal. Although my metabolism, was pretty quick to shift over to fat and ketones, I did have a remarkably elevated LDL cholesterol and ApoB, and I think the jury's still out on that, whether that sustained super hyper elevation. I err on the side of caution, and I'm not willing to take a statin, but my genetics are such that I am a hyper absorber.
Right.
And I do have a mutation in the MPC1L1 transporter that in the gut, so a tiny dose of ezetimibe, actually I just split it in half, and will drop my ApoB and LDL in half. And that was like, I thought it was very unique to me, but I talked to other people that have that, although my mutation is particularly unique.
Mm.
But it also lowered my triglycerides a bit, and I don't really have
Hmm.
any side effects associated with taking that drug. It worked very specific, very mechanistically, and what I would be concerned about is taking a statin, especially a lipophilic statin that crosses the blood-brain barrier and decreases cholesterol synthesis in the muscles and in the brain, especially because the brain, I mean, cholesterol is amazing and it does
Yes, it
certainly
is. Yeah.
benefit from a neuroscientist
Yeah.
perspective, and also from if you're exercising, the tissue remodeling associated with skeletal muscle protein synthesis following resistive training has a high requirement for cholesterol. So you do not want to be globally, inhibiting the synthesis of cholesterol. So that's like these are
Yeah.
things like really not discussed by statin
Yeah.
enthusiasts.
Yeah, it's an important point, and maybe we can harp on it for a minute because I mean, I was just talking to another patient of mine yesterday, and they're trying to get his LDL below 55. Like that's the newest of these recommendations, and it sounds like. I mean, I worry about this too from a lot of different reasons.
Yeah.
I mean, certainly the lipophilic ones getting into the brain, but what you see in some of the studies too, and which is interesting, that statins sometimes can have pleiotropic effects as an anti-inflammatory, and using in anti-cancer protocols as well. So I guess I kind of come to here is that it's not a one size fits all. It really depends on the situation. But I do worry about driving people's LDLs down to 50 and using really high dose statins to do it for the reason you just mentioned, along with its effect on the mitochondria as well.
Yeah, and the dose is important. The side effects come, when you're pushing, 20, 40, 60 milligrams of the stuff. But, my parents are on, baby dose of statins. And in certain contexts, I think it's totally okay because you do have the pleiotropic effects. So
Yeah,
if you're
yeah,
not getting the benefits from the LDL lowering, there are other benefits you are deriving from it. And I do think the negative effects are highly dose dependent. I remember my mom took a pretty big dose and it really made her sick, very
mm,
much sick. And I think she had to change to another one, but taking a tiny fraction of the original dose. And when I was in, these drugs came out and they gained popularity in the mid 90s. And I was
yep,
doing like landscaping and work outside on the farm. And I worked with guy that was pretty active, and he started using it, and it crippled him. Like, I mean,
Yeah.
he had
Yeah.
crippling pain and things like that. And I remember it because I think the original, statins were prescribed at a pretty high dose. And I think now we know that,
Yeah.
that's not a good thing to do.
The Health Optimization Medicine Conference is happening. 2 days of events, October 2nd and 3rd, Chicago, Illinois at the Drake Hotel. CMEs available to practitioners who need them, just 150 people, with amazing speakers on the cutting edge of health and wellness. This is a community. It's not your average conference. If you're interested, go to homehope.org and save 25% on your ticket by using Conference 25 at checkout. I hope to see you there. Yeah. Speaking of, I mean, we're on the topic. Did you see the recent study on metformin and VO2 max? That was kind of crazy too. Yeah. The quick and dirty of it is that, metformin is an anti-diabetic drug. It's been around forever, right? But it's also a complex 1 inhibitor in the mitochondria. So it actually causes more oxidative load. And the goal of this drug, at least on some levels, to force you make more mitochondria to keep up, as a result. It also has, a decreasing blood sugar. But they found that if you were using it with exercise, your VO2 max increases were 50% less than those that were not using metformin. So a big deal, right? And I think we always have to remember that there's always going to be like a risk versus benefit, and there's always a network effect on this. And even with statins, like we see people's hormones drop to the tank, right? We see their testosterone level go down. We see, some of their other adrenal hormones go down. If you're not compensating for these things, and that's what the main aspect of the study was, like, if you're taking metformin and you're metabolically relatively healthy, you should not be taking metformin.
Yeah. We studied it in the context of cancer cells. So my former PhD student, Nathan Ward, he has a lab now at the Moffitt Cancer Center. Yeah, I mean, we published over 10 years ago and showed that superoxide production was elevated in response to that. So it's functioning as a weak mitochondrial toxin. And when you're taking metformin, your liver is kind of de-energized in a way that doesn't, do the Cori cycle too well. So if you're making that lactic acid goes back from the muscles to the liver. It's also because you're kind of de-energizing the liver in a way, you're decreasing gluconeogenesis. So that has the glucose lowering effect, but it impairs, various aspects of liver function through, increased reactive oxygen species, complex 1. And we measure that with dihydroethidine. And it was very clear that you can kind of see that with metformin. And I experienced, when I was experimenting with metformin, I stopped a long time ago, but really intense exercise made me dizzy and kind of like really tanked me.
I saw this with some of my patients as well, when they were using it. I had a couple of patients that were on it off label in the beginning, and then I saw how terrible they felt after exercise. I'm like, there's something going on here. So that signal has been around for a while. I mean, maybe as a quick primer on how the ketones work in the mitochondria would be helpful here, because there's obviously multiple different types. Like, we talk about oxidative phosphorylation, we talk about the complexes, like the people that are listening on this podcast, we talk about these science, very deep, sort of into the electron transport chain a lot. Like, if you're thinking about ketones itself, why are they potentially more efficient than glucose, for example, when we are trying to make energy in the mitochondria?
Yeah, so ketones can be an energetic substrate, in the brain and the mitochondria. And when ketones are metabolized to generate ATP, our energy currency, right, they have a unique capability. And this was first shown by Dr. Richard Veach, who published in the heart. And we are assuming this also happens in the brain. And there's like cell-based studies, but he had a very unique model. He had a working heart preparation where he can actually measure the hydraulic efficiency of the heart, like the pumping of the heart, in the context of like glucose and insulin, and then insulin, without insulin, they give ketones, and essentially showed that the hydraulic efficiency of the heart was remarkably enhanced when it metabolized ketones relative to glucose. And that hydraulic efficiency, Sato was the first author, it was like 1995, they showed this, was primarily due to oxidizing Q. So you had less leak of the electrons at the level of, complex 1 and 2, the semi-ubiquinone site. So, but yeah, by oxidizing Q, you have basically tighter electron flow. And so tighter electron flow, you get a generation of more reduced intermediates to drive the the electron transport chain, so through the TCA cycle. And the reduction in superoxide, which is a precursor to more reactive intermediates, so that goes to hydrogen peroxide and then can go to like hydroxyl radical. And then that's very, very damaging to membrane lipids and proteins and nucleic acids. But superoxide in and of itself is not super reactive, but it gets broken down to other things. What ketones do, it reduces superoxide production overall. And we see that. I spent my whole postdoctoral fellowship developing ways to measure ROS production using dihydroethidium and many different ROS dyes. That was like, I spent years doing that. So that was very apparent in cell-based systems and also like brain slices and tissue slices and things like that. So you're making less superoxide, but it's also enhancing production of endogenous antioxidant mechanisms from, superoxide dismutase to catalase to glutathione, things like that, NRF2, like these things are all, and it's doing that through a number of different mechanisms, some of them even epigenetic, we know now through beta hydroxybutyrylation. So there's multiple mechanisms through which ketones can be energetically favorable, but also reduce ROS production and endogenous ROS production and also enhance endogenous antioxidant capacity of the cells. And it can vary between tissues too. So a lot of what I'm talking about from my experience is the brain, but it happens presumably like in the muscle and other areas. I've not studied muscle, but mostly what we study is the brain. And it does happen in brain cells for sure. And then other investigators have looked at the heart.
Right. And this is a direct correlation to some of the research that you were initially doing with the Office of Naval Research and looking at preventing Navy SEALs from having seizures at pressure, right?
Yeah. Yeah. Because as you know, like the limitation of hyperbaric oxygen therapy or diving, especially with a closed circuit rebreather, is central nervous system oxygen toxicity. If you stay down too long, even if you don't get CNS oxtox, if that duration is very long, you sort of get pulmonary oxygen toxicity. So that'll happen even without pressure. I mean, you're in a room with 100% oxygen within like a day or two, you'll get, you'll die of pulmonary oxygen toxicity.
Yes. Yeah. Continuous people on ventilators. We see this all the time, right? So yeah.
So these are considerations. Ketones tend to help both situations, but they do by providing the brain an alternative form of energy from a bioenergetic perspective and also an antioxidant perspective. It's working through that. And also it's activating systems like glutamic acid decarboxylase, and that converts more glutamate to GABA.
Right.
So there's a benefit there. And we've shown that in various like animal models of diseases, but the wild type animals, which animals that don't even have diseases, also you get more glutamate to GABA. So I think and then we've studied adenosine and the NLRP3 inflammasome, and there's multiple mechanisms. I thought it would be sort of easy and we'd identify like a single mechanism that was the driver, but it does not. It seems to be very context dependent, in some cases tissue dependent, and like situationally sort of different too. But that's metabolism, right? So
that's right. Everything's all connected, right? Everything. Yeah.
Different hubs throughout the network, and you can kind of hit the network in different ways. And I think of the physiological system is like, our bodies are basically networks and hubs that are more relevant and context dependent than other hubs.
And this is what we talk about all the time, right, at Health Optimization Medicine, whereas everything is all networked together. If you move one node in the system, things are going to compensate. There's feedback loops everywhere. This is like the classic is go get TRT. Everything else is going to go down, all your other hormones, if the testosterone is going elevated, right? And so your thyroid is going to go crazy. And so it's such an important thing to know. And like, you've always seen those diagrams, like of the spaghetti looking stuff on the wall. That's all the diagrams of everything that's happening for energy metabolism. When you're thinking about exogenous ketones specifically and how to utilize these most effectively, what are like the best use cases here? Like what's the dosing expectations we might have for like certain types of various types of performance, like, cardiometabolic, you talked about the heart, for example, stress resilience, mood, like are there particular types of ketones that are better than other ketones for particular situations? Or how do you think about this, Tom?
Our research program sort of got spearheaded by looking at ketone esters because they were like sort of the most potent ketogenic agents. So I just went right to the top,
Right.
So the first one was a beta hydroxybutyrate monoester, and that did not have anti-seizure effects, although the NIH in Oxford had studied it for exercise performance and seemed to be a signal there, although that's kind of debatable. I think there's an performance enhancement under certain environmental conditions and under stressor conditions, like if you're really sleep deprived, hypoxic or hyperoxic.
Specifically with the esters, you mean? Or
Yeah, with the
okay.
esters, I think they do
Okay.
have certain use applications, especially for military and extreme environments.
Mm.
Absolutely.
Okay.
Although the beta-hydroxybutyrate monoester did not prevent seizures, so we sort of developed with the late Patrick Arnold that we developed a 1,3-butanediol diester with acetoacetate, and it generates in the blood a beta-hydroxybutyrate and acetoacetate, which was really important for preventing seizures.
Mm.
And some of the reasons for that is that it maintains a redox balance. If you get a big dose of BHB, that can cause reductive stress, kind of.
Yes. Right. It's a reverse stress. Yeah. Yeah.
But the ratio of acetoacetate, the beta-hydroxybutyrate, would kind of mimic that which was found in the diet. So that was like something that was interesting. And then the acetoacetate spontaneously decarboxylates to acetone.
Right.
And acetone kind of had interesting effects on the receptors, and has like a subnarcotic levels of acetone seems to dampen hyperexcitability. So
Okay.
there's there's a lot more to unpack there, but just different ketogenic agents, but what we didn't know at the time, but we did a study with rats where we fed them 1,3-butanediol and the esters that were derived from 1,3-butanediol. And if we give them high doses chronically, we saw some liver abnormalities and see some abnormalities maybe in the blood work too a little bit.
Yeah.
But with
When
the
you're talking,
histology, you start to see sinusoidal dilation, and you start to see fat droplets, and you start to see pre-necrotic effects in the liver that were concerning to me. And also with the human randomized controlled studies that just came out in the last 2 years, the maximum dose of 1,3-butanediol is 34 grams, I think. And when subjects consume that, 40% of them got dizzy. And these were healthy, robust subjects. Imagine giving that dose, which is not really that high, to subjects that are older or to have cognitive. So 1,3-butanediol is an alcohol. It's a di-alcohol technically.
Right.
It has
Right.
to go
Yeah.
through alcohol dehydrogenase and aldehyde dehydrogenase, and it kicks off a BHB aldehyde. It's short-lived, but if you take a lot of it, then it can stick around, and aldehydes are not good to have.
Yeah. Those rat studies that you're talking about when you had the elevated liver enzymes in them, was it a dose that would be relevant to humans at all? Or was it something, and you talked about how long they were taking it as well. Maybe those would be helpful, because I know there's a lot of controversy here. So
the dose with the 1,3-butanediol specifically would be a dose that would keep a human at 2 millimolars ketones throughout the duration of the day.
Okay.
So for me, someone like me, that's like 100 milliliters per day, but that's
a
what you
lot
need to do to be in therapeutic ketosis, just to keep that 1 to 2 to 3. And that's 1,3-butanediol. And now the beta-hydroxybutyrate monoester is technically 1,3-butanediol esterified to BHB. It's 51% molar concentration, 51% chemically 1,3-butanediol. So when you take that, you are delivering 1,3-butanediol too. And I think the take-home message is that there are, these molecules have been around since the 50s and 60s, 1,3-butanediol, and now there are definitely new molecules that are equally or more potent that have no toxicity. So, we've inadvertently killed quite a few animals with these agents, just trying to figure out how to dose them when we first got them.
Right.
And that would create a lot of confusion and sort of, pain on our end to do that, to really titrate the dosages down. But when we're working with the glycerol triester of acetyl, or the glycerol triester, or various ketone salts, the racemic salts seem to be, very, especially when you combine them with MCT, and then we have a whole catalog of different agents. We never get any toxicity in agents and ketogenic agents that are not 1,3-butanediol or 1,3-butanediol, associated molecules. They have their place, and I think, they were a big part of our original research, but now we like to pivot it away towards molecules that don't have any long-term toxicity or, with chronic use. Also, 1,3-butanediol, because it is an alcohol, it can create dependency and also withdrawal symptoms if you're taking it and you get off of it. So solid evidence, with that too.
Is the dosing super high for that too, as far as how much you're taking, or you're not really sure at this point?
Same dose as ethanol. So actually a little bit lower. You get the withdrawal and the chronic, but it would be equivalent to 3 shots per day, 30 milliliter shots a day. Someone my size, 100
And now
kilograms.
30 ml shots of 1,3-butane you're talking about,
Yeah.
right? Yeah.
Yep.
Is it common? I just don't understand. Maybe I just don't know. Is it common for people to be using that much on a regular basis, do you think, at this point? Or is it not that common overall when people are
Well,
using these?
the shots, I think the shots that I was taking, I don't know. I'd have to figure out the dosage. It's like
Yeah.
10
Yeah.
to 10 to 30 milliliters. I think, one product is 30 milliliters, I think maybe in one shot or whatever.
Gotcha. Okay.
The point is like the amount that's needed to produce a level of ketones that's therapeutic
Right.
is the
Yeah.
amount that actually causes
Causes the liver stress. Yeah. Yeah.
liver stress, but also over time, and we're talking like months, used every day chronically.
Dependence
So
potentially.
that's sort of the
Yeah.
issue there.
And
With
that's the
that
dependence
said,
piece, right? Yeah. Yeah.
yeah, with that
Yeah.
said, I think
Yeah.
some of these molecules work really well in formulations, right? So we saw that toxicity, animals died, they become
Yeah.
ketoacidosis. So what we did, and actually Chilla, my wife, published a paper where we just simply took the ester and mixed it at 50% MCT with
Mhm.
the ester, and that worked. Everything that I'm talking about here is in context of acute administration. So
Sure.
you're still getting that like toxicity associated with it, and that concerns me. So if you are going to use like 1,3-butanediol or the ketone esters, think about formulations. And we've did some nice work with the ketone salt and ketone ester formulations for seizures.
Mhm.
And then also when you deliver an exogenous ketone, whether it's an ester or salt with MCT, which is a ketogenic fat, that significantly delays gastric absorption.
Right.
And then the MCT generates endogenously, like your own ketones.
Right.
And then
Right.
MCT can cross the blood-brain barrier and be used as fuel. So and then
Right.
you're also slowing the digestion, and you're also slowing the metabolism of 1,3-butanediol in a way that's sort of doesn't produce as much of that BHB aldehyde and stress the liver.
Yeah.
So I think
This is
it's sort
helpful.
of a
Yeah.
formulation issue.
Yeah.
However, there's things that are available, things in the pipeline. Like if for everyday use, you want to use a BHB electrolyte. So I think that would be, however, for use applications, you might want to use the esters and you can formulate it in the ways.
To make it
And
a
then
little
you
bit
have the
safer.
different
Yeah.
enantiomers of BHB, right?
Right.
So
Right. Right. Yeah.
the market share has really focused on D beta hydroxybutyrate because our body makes mostly that. Although if you're on a ketogenic diet and you were to take out somebody's heart, 30% of that is L-BHB, believe it or not. So there's a metabolic pathway that's producing the L. And L-BHB delivered as a supplement produces a cardiac output that's 5 times higher than the D. So this was published in the Journal of American Heart Association and also in the American Heart Association journal called Circulation. And we don't know why, but it decreased peripheral vascular resistance. And there's some speculation that it could be nitric oxide. The endothelium gets relaxed with BHB, with the L-BHB, just because when you consume the L-BHB, it's resistant to ketolysis, so it stays circulating more, so it's hitting all the different
Interesting. Okay.
ketone signaling, and that could be the GPR109A receptor, could be adenosine. Like our adenosine signal is really high in our metabolomics. We have not published that yet. So
Yeah.
adenosine is sort of, ATP, adenosine triphosphate. If adenosine is simply part of normal metabolic processes,
Right.
and it builds up during the day.
Mhm.
And the most important thing to remember is in regard to adenosine is that it is a very potent vasodilator.
Yes.
Like if you give adenosine, you could if you give someone a shot of adenosine, I think they just die. Like they just like.
Well, it
you
depends
have-
on the shot. We use it. We use
Yeah.
it therapeutically for somebody in supraventricular tachycardia because
Absolutely,
it-
yeah.
because
It's
it blocks.
potent. I mean,
Yes. Yeah.
my point is that it's very potent
Yeah.
and it's a potent vasodilator. And when you're in ketosis, when you deliver an exogenous ketone, the adenosine levels go up quite high, and that could maybe give a little bit of sedating effects, especially with the esters that are a little bit higher. Some people get a little bit sleepy.
Maybe the
with that.
dizziness as
I
well
think
that you
it's-
mentioned too. Maybe I
Yeah,
don't.
maybe
Yeah.
dizziness.
Okay.
But it also has neuroprotective effects. And adenosine, there's a book this thick written by Dr. Susan Massino on adenosine, and she's a friend and colleague of mine. And it's just the adenosine receptors and metabolism is a very interesting area. But I think importantly, like if your ketones are elevated by virtue of fasting, diet, or supplementation, adenosine and adenosine signaling is going to be higher. That's going to cause vasodilation, and that could increase brain blood flow and blood flow to peripheral tissues. So I think there's a strong rationale for ketone supplementation for recovery. So enhancing that blood flow to peripheral tissues, to your brain, and just can overall enhance it. And we've seen that in our wound healing model. I mean,
Right.
there's plenty of publications out there, like 20 or 30% increase in brain blood flow with acute administration of ketogenic agents. So that's something not quite talked about, but you have, American Heart Association journals have like published. And it seems to be, you could give DBHB and LBHB, but DBHB gets burned up as energy quickly, and that's a good thing. And the LBHB stays in circulation longer and may convey or endow like the system with more of this vasodilation effect, this reduction in peripheral vascular resistance. And I think that's really important to me. We have not done the elegant studies to show that. We just showed the effect, like with a Doppler blood flow measurement.
Sure.
But we have not mechanistically dissected that. And I don't think anyone has, but I'm aware of a few publications that should be out soon.
This actually brings up an interesting point of the dovetailing of you and I many years ago, which is hyperbaric oxygen therapy, right?
Yeah.
And because when you and I talked about traumatic brain injury and hyperbaric oxygen therapy, you started talking about this vasodilatory effect, which potentially could be very helpful in the post, concussion optimization of getting them better, right? And I know you've been very involved in hyperbaric medicine for many years in your lab. And how do you think about the combination of hyperbaric therapy and ketones in general in various ways?
Yeah, I do think there's a synergy there with hyperbaric oxygen and ketone therapy. I mean, that was what got us funded, is that ketosis prevents oxygen toxicity seizures, but I was studying the negative effects of hyperbaric oxygen, really.
I know, I remember.
Levels, right? Yeah. And, but by doing those studies, basically you realize, oh, okay, so hyperbaric oxygen is very therapeutic for 14 different FDA approved applications. Then there's these emerging applications that are actually more interesting that is just ongoing research on that, like traumatic brain injury, PTSD, recovery, and things like that. And then with ketones, the ketones are sort of mitigating that potential oxidative stress issue that you could get with too much hyperbaric oxygen, right? And it's also, our brain's capacity to function is limited by two things: oxygen and substrate for energy, glucose or ketones. So with hyperbaric oxygen, by reoxygenating the brain and also giving ketones at the same time, that's a stimulant that happens, in the context of when you're in the hyperbaric chamber, but then you get that pulse of oxygen and also reactive oxygen species to some extent. But just the cycling of oxygen can actually have long-term effects too, and activate genes and other adaptive mechanisms that we call. But I think the benefits that you can derive from hyperbaric oxygen therapy can be augmented if you're giving an alternative fuel that can further enhance cell metabolism and energy before, during, and after that, I think, in all contexts. But I think from our perspective and from military operational perspective, it makes high concentrations of oxygen more tolerable and also more safe. And it makes the warfighter more resilient. And that can be achieved, with fasting. Well, that's what they fasted rats, and
Sure.
caught my attention. And it was like, oh, there was a number of and then then the diet had a great track record for seizures, and Office of Navy Research didn't want to really fund ketogenic diet studies. So they said, well, try to investigate, the diet in a pill. So I was like reluctant. I was like, okay, I'll try it. That seems like a big tall order, but through testing a number of different compounds, we, settled on the ones that work. And I think we're kind of just scratching the surface, and it's a very nascent field, even though we've been at it for, 20 years. I think there's many different molecules. We don't know the dosage, timing, and scheduling. And then there's very different use applications. We just know that ketone, it's almost like creatine. When creatine came out, the data was pretty compelling. And in 1995, in my exercise science, we had to write, about 3 ergogenic age. And I wrote about creatine, and it failed because the professor was like, I've never even heard of this. There's no evidence.
You're 30 years too early there, Dom.
I was reading Muscle and Fitness and a couple, it was like Muscle Mag Internet. They were talking about it. And I was a little bit over enthusiastic, but now we have 1,000 randomized controlled trials, right, on creatine.
Right, sure.
So I see ketones as sort of, there's a parallel there. I think ketones will explode and be the next creatine. And it's already gaining
Sort of there,
traction. But I
coming
do
there. Yeah.
think we need to have a high bar on the rigor of the science. So there's a lot of research being done that's driven by industry. And
Yeah.
I don't think the dosage, timing, and scheduling. And I think that could involve a whole research project that we're working on is actually like pulling the data to figure out, were the right tests done, were the dosages right. And I think there's a lot that we need to get right in for the foundation of understanding this before we start applying this to like big federally funded research projects. And I think that's going to save a lot of time, effort, and taxpayers' dollars
Yeah.
if we do that. And and I'm really excited to kind of leading a group to do that.
That's
And we're
great.
just in the initial stages of planning it, but that's a big project that I'm working on.
I look forward to the controversy that you will bringing that such,
I think
because
it will be a little controversial.
yeah, I mean, and that's okay. Like, because you're coming at from like the research side, from the rigor of looking at all the data, and that's really what matters the most. I think, for me, as you know, Dom, always it's the clinical application, right? And then that's what I know what you've been working on so hard is like you've been doing animal studies on, with ketogenic diets for a long time, and now it's about, and it has been for a while, like how did this actually work in humans? Like what are we seeing in humans? And there's only so much you can know from an animal model. And I remember just going back a little bit, you talking about the adenosine system and blood vascular dilation, and we were talking about wound healing, and like we love to do a study where we did combination of hyperbaric oxygen with exogenous ketones for healing diabetic foot ulcers. But it's very difficult to get this stuff approved and done because again, there's a lot of money that's involved. But looking at this mechanistically and the things that you've been doing has just been transformative, for my practice, right? Because as somebody that's involved in hyperbaric medicine, I use ketones when somebody has a concussion. I use ketones when somebody comes with an acute injury. I also use other things too, but it's for all the reasons you just mentioned, along with the other part of it where, there's something about recovery here that I wanted to kind of go into, right? Where like you mentioned recovery a little bit with ketones, and there was a study that you were a part of not too long ago talking about exercise and ketones specifically. Maybe we can go into that because there was a lot of thought, at least in like the fad time of ketones, that everybody needed to be taking ketones to perform better from an exercise perspective. You mentioned the esters may be under certain duress overall. You can talk about that again if you want, but maybe talk about that study a little bit and what you guys found. Maybe that was underwhelming and maybe more compelling than people realize.
Yeah, well, we've done numerous studies, and I can give like the punchline and the take-home messages from different ones.
Yeah.
And I think, ketone salts and ketone esters and probably MCT too, but we haven't studied that. But exogenous ketones elevating, blood levels to 1 millimolar, actually getting a little bit higher creates like a little bit of an acidic load, I think, and the body has to, there's renal and respiratory compensations. So
Sure. Yeah.
I think, people out there listening, higher's not better. I've been higher before and gotten the situations where I could just tell you higher's not better. If you're achieving a 1 millimolar, that's a significant amount of energy, like for your cells and your brain to use. And so like 1 to 2 is pretty significant. And then also the level that you're measuring is not taking into account ketone utilization. So athletes they're dumping a lot of ketones into their tissues.
Sure.
So that 1 millimolar is almost like spilling over in surplus reserve, right?
Okay.
Your tissues are quickly sucking it up. So the level in your blood is ketone production, ketone utilization, or ketone consumption if it's exogenous. And that gets taken up far faster in someone who's like an athlete, even at rest, right? So
even somebody that's not fat adapted or anything, we're talking about like a regular athlete, no
Yeah.
matter who they are, right?
Yeah.
Right.
Yep. But I think, I guess exogenous ketones really got spearheaded by DARPA, and that was like a NIH Oxford project under the DARPA Warfighter Dominance Program, Warfighter Optimization. And that was in the early 2000s, that was funded. And it looked at rowers and it looked at exogenous ketones under situations, looking at power output and things like that. And there was definitely a signal there. It's like 2 or 3% from the original data. And these were elite rowers. So that's significant. And
Right. Sure.
subjects who are at the top in their field, but it is not really translated out into the peer-reviewed randomized controlled trials, right? There's a weak signal there. And I would say that the benefits of exogenous ketones on exercise performance are really underwhelming. I do think there's a benefit there, but I think we want to think of like dual fuel. Like it's not just ketone, it's like
Dual fuel.
ketone,
Yep.
glucose, MCT, like, lactate, alpha L
Lactate.
polylactate. That was used in a product called Cytomax. I think we should think about a variety of different fuels that could enhance
Sure.
anapleresis, like energy production in general. However, ketones have the unique ability to preserve brain energy metabolism and in just general mitochondrial function under periods of oxidative stress and metabolic stress. So that's where ketones really shine. And I think creatine works that way too. Like when the system gets loaded, creatine can donate the phosphate, creatine monohydrate gets converted to creatine phosphate, and that can, generate ATP in the context of getting a couple extra reps out. But ketones have a remarkable ability to sort of provide that alternative energy. And from our perspective, it tends to work better in the context of stress. That could be sleep
Right.
deprivation.
Sure.
It could be hyperoxia, which we've studied, or hypoxia, which we also studied, or limited glucose availability in the context of a calorie deficit, right? You can preserve energy by just, enhancing metabolic flux with ketones. So, but if the normal healthy athlete that is just doing their day-to-day events and consuming ketones, I think they're going to be a little bit disappointed if they're
Right.
using ketones. However, they might, from a muscle performance, energetic, however, I think they are in some ways enhancing the central nervous system in a way that could be contributing to reduction in perceived exertion and, maintaining CNS function and optimization, although the signal is pretty weak.
Okay.
So I have to say that because I have been on, studying this, and the signal is there in the context of a stressor. So that could be physical fatigue, mental fatigue, environmental stress and things like that. So I'm making a very broad statement, but if, the systematic reviews, meta-analysis like that looks at like ketone augmentation or ergogenic effects in exercise, it's still, the jury's still out.
Understood.
And
Right.
however, if you were to look at, the effect of ketones in the context of extreme environments, then that's where the signal is, there. And that's was the appropriate, use case in regard to like military operations and things like that.
Yeah.
And we still do not know the optimal formulation, dosage, timing. So that's like data even derived from formulations that are probably far from optimal.
Sure.
And in many cases, they're always testing a single like monotherapy, a single agent.
Yes.
Where the real benefits come from like combining different things.
And that's always the hardest thing to study is combined therapies together. But you also mentioned there might be some additional, maybe more positive signal on the recovery side from exercise as well, right?
Yeah. And I think so a lot of these things have been tested, almost like caffeine. You give a dose and look at power output kind of thing. And, we kind of did that in different anecdotal things where you look at power output and oxygen consumption, you get more power output if you're like fueling with ketones.
Yeah.
But I think the real thing or the real benefits will be using ketones chronically over time to enhance the adaptive responses to exercise by reducing systemic inflammation, augmenting blood flow, reducing peripheral vascular resistance, augmenting cardiac output, reducing, the inflammasome activation and reducing oxidative stress in general.
Makes sense.
So
Yeah.
I think that's where like the real benefits are going to be.
Yeah. Well, you mentioned a couple times therapeutic ketosis, and I think before we finish up, I have a couple more things, but just to kind of talk about this, right? When we talked about like keeping the esters up at 2 millimolars, that's going to cause liver toxicity in patients, right? You mentioned that giving more energy at 1 millimolar is typically good for you, how you feel, and how a lot of people are going to feel. When you talk about the range matters, of course, and it also depends on the person. How do you think about therapeutic ketosis at this point now, given all these years that you've been doing this? Because there's a huge range. I just thought it may be helpful to kind of go over that briefly.
Yeah, I think the optimal approach for like overall wellness and longevity and things like that would be a low carb diet that's like skirting right on the edge of ketosis, because that means you're optimizing fat oxidation. So
Right.
we're
Right.
like
Right.
you're, like right before a meal, your ketones go up a little bit. So that means like you're keeping your body hungry for glucose, that insulin sensitivity is high. And then periodically, 1, 2 doses a day, three doses, do supplemental ketosis, I think would be kind of beneficial. And that doesn't have to be chugging an ester. That could be like ketone salt, ideally a DL, beta hydroxybutyrate salt, with electrolytes, and you don't have to, similar electrolytes to a common electrolyte supplement.
Sure.
So you're getting
Sure.
the electrolytes, you're getting the salt, and you're you are boosting the ketones in circulation. And
We're talking about levels of like what here? What if on millimolar concentration? What would you kind of range there for like this kind of person?
yeah, I mean, there's data coming out showing that like 2 or 3 grams of a BHB salt or BHB is enhancing. I'm trying to think, there's a Japanese study that used 2 or 3 grams and it really augmented sleep in a way that improved a deep sleep.
Mm-hmm.
So there's a sleep study by Japan, and I recently talked with them, and yeah, they're just using 2 or 3 grams a day. And then another study published by the icon in protein, Jose Antonio, very well known in the ISSN and different on protein metabolism. He published a study looking at the D and the L-beta hydroxybutyrate showing increased reaction time with L-BHB, and it was only like 3 grams. So I used to always think more is better.
Yeah,
I think
yeah.
this saves people money. They can use relatively small doses that you can acquire through ketone salts,
Right.
and avert the taste and the cost of the esters.
Right.
And more is definitely not better. I could tell you that from a scientist. Sometimes when levels get into that 2-3 range, unless you're treating something with an overt pathology, but
Right.
normal healthy subjects, once you get into that 3 to 5 millimolar range, then you're basically making them sick. You're creating an acidic load that needs to
Yep.
be mitigated, and then
Closer to
it's like
ketoacidosis.
energy
Yeah.
surplus,
Yeah.
right? It's like
Yeah.
you're putting more energy into the system and creating an energy surplus.
So from like a millimolar concentration level, we're talking about somewhere around 1, is like, or maybe even lower than that, having significant benefit. And then 3 grams of a beta hydroxybutyrate salt may not even get you that high, right? But you could still get significant benefit from that, is really what you're grabbing at, right? So
Yep.
okay. Yeah, that's what I was thinking, because I've been thinking more and more about this in the range. Like when you and I first met many years ago, we were talking about the ketogenic diet with cancer and cancer patients. We're talking about glucose ketone indexes of 1, like super low glucoses, super high, ketone levels. But, and I think that's a very different subset of people, right? We're really talking, what we're talking about here is that we're talking about people that are looking to be optimized and keep them metabolically healthy, metabolically flexible. So that range seems to be a more optimal range for people like in that capacity, right?
Yeah, for sure. Yep.
I think that, to wrap up here, Dom, just a couple more things. I know that you're always sort of on the cutting edge of research and doing lots of really interesting, novel things in here. So what are you most excited about in the next 6 months to a year that either you're working on or other people are working on in the field that you're really kind of really excited to see what the results look like?
Well, we're working on a couple different NIH grant proposals.
Okay.
And one, if it's funded, it will be, nowadays it's hard to get NIH funding, but it will be basically looking at ketone metabolic therapy in people that do not have any overt pathology, but just looking at their cardiometabolic biomarkers.
Okay.
And how that and other factors, objective biomarkers and subjective, and also things like strength and a number of different things, how that changes over time and can mitigate the cognitive decline that's typically associated kind of with aging. So we're thinking about doing, proposing to do long-term studies.
Nice. Nice.
Years studies, and then tracking with a very high level of granularity and precision a number of cardiometabolic biomarkers, cognitive, mental health, like, do the GAD-7 test, PHQ-9, we look at sleep, DEXA scans and things like that, to basically an intervention for healthy aging is what we're kind of targeting. Because if you have someone with metabolic syndrome, but not like overt type 2 diabetes, that's the time to intervene to prevent them from being, a big strain on the medical, or getting all the comorbidities that's associated with, sliding into that category of overt diabetes. And the NIH does have a call for proposals. It's not fully out yet, but we're hoping to target that. And this will be a relatively larger sort of proposal.
Wow, that's great.
I'm excited about that, and a number of other projects, DOD related too. So
yeah, I know you have one on hyperbaric therapy and traumatic brain injury. Maybe you can talk about that briefly.
Yeah, so that's like a state-funded project through the university, $28 million project, like total grant size. And that project is almost halfway through. It's blinded, so we don't know, but it's the use of hyperbaric oxygen for traumatic brain injury with or without PTSD, without a ketogenic intervention for this initial study. But it's the biggest hyperbaric, therapy study that has ever been done. It will be at least the most costly and most comprehensive scientifically wise,
Yes.
but it actually uses a valid control or sham where subjects get into a hyperbaric chamber and they feel a pressure difference, but we pop the pressure up initially in the beginning to make them think they're undergoing pressure, but we stay at 1 atmosphere, and it makes them think that we pressurize the
Yeah.
chamber.
Yeah.
And that's really important because previous studies, as you know, use hyperbaric air, and that's not good either. So you want to keep it 1 atmosphere.
Right.
So we have the proper shams. We have, a number of different PIs getting blood work, every possible biomarker you can think of. So we'll have a lot of data to analyze over the course of that. And I'm just a consultant on the project. I was the guy studying the negative effects of, hyperexogenous, but this is a really, really well-designed study. And I think it's going to definitively answer the question and, for this particular use case scenario.
Yeah. I'm very selfishly asking you that question so that you can tell everybody about what's happening. I know it's not the direct things that you work on, but all the years in hyperbaric medicine and all the support you've given has been gigantic for the field. And this particular study is a really great one. And I know we're not using the ketogenic diet in this one, but in the real world, this is what we do, right? Which is we combine the ketogenic diet or ketogenic supplementation with patients that have traumatic brain injury, with PTSD, and see dramatic changes. Yeah. And Dom, it's always great to have you. And we just obviously scratched the surface. I had like another 75 topics that I wanted to ask you about. But as we wrap up, where can people find more information about what you're doing? How can they support your work? Because again, what you're doing should be supported, and it's such great stuff.
Yeah, thanks for asking. Well, Metabolic Health Initiative, that platform. So that's an ACCME accredited educational platform. You can get CME credits for that.
Right.
Ketonutrition.org is my information website. I don't sell anything. Like I don't have any company or sell anything, but we have, products on there that I've tested. There's a blog on there, various resources. The Metabolic Link podcast too, which you're familiar with. You've been
Yes,
on.
I've been on. Yes. Yeah.
Podcast,
Yeah, that's been great. Well, Dom, I wish you a great rest of your day and keep up the good work. And the last thing I want to mention to everybody is that Dom is actually going to be one of our speakers at the Health Optimization Medicine and Practice Conference, October 2nd and 3rd in Chicago, Illinois. So if you haven't gotten a ticket, you can go to homehope.org and you can go to our events page. You'll find Dom's going to be there. We're going to have a lot of great speakers. We're going to have I'll be speaking, Dr. Ted Achacosa, who's the founder of Health Optimization Medicine. We'll have Kiran Krishnan, who's the former founder of Microbiome Labs. We're going to have JJ Virgin. We'll have Dr. Elizabeth Yurth, who's at the Boulder Longevity Institute here. She's fantastic. So check it out at homehope.org. And Dom, what are you going to speak about? You just gave me your title in the message. What's your topic going to be?
Oh, yeah. Like science and application of ketone metabolic therapy, and then associated testing that is being done in research and being done like personally. So yeah.
Nice. And maybe we can get Chilla to bring some ketones with you so we can have some ketones to fuel us. But everybody, thanks for listening to this another episode of the Health Optimization Medicine podcast. If you like this, don't forget to like and subscribe below, and we'll see you next week.